right now, like as you sit there just listening to this, there is an entire shadow circulatory system operating inside of you.
Yeah, completely under the radar.
Right. I mean, if you were to look at a standard medical textbook, you'd see the heart portrayed as this massive, loud, beating machine. You'd see all those blood vessels rendered in those bright red and deep blue highways that are practically impossible to miss.
Oh yeah, the classic diagrams.
Exactly. And that plumbing is loud, it is highly visible, and it forms the bedrock of how we intuitively understand keeping the human machine running. Blood goes out, blood comes back. It's simple.
Very simple. But it's actually incomplete.
Right, because what if I told you that the blood doesn't actually stay in the pipes?
It definitely doesn't.
No. Every single day, liters of fluid are actively leaking out of your bloodstream. It's just seeping right into your tissues, carrying with it this chaotic mix of raw proteins, cellular debris, and, potentially lethal bacteria.
And if that fluid just sat there, I mean, you would quite literally swell up and die within a matter of days.
Wow. Days.
Days.
Yeah.
The fact that you don't is entirely thanks to this shadow system. It is a parallel universe of microscopic transparent vessels and these high-security checkpoints running right alongside your bloodstream. And it does all of this in total, absolute silence.
So that is our mission for this deep dive. We are going to exhaustively map out this hidden network, the human lymphatic system. We're going to explore a system that handles a massive amount of your fluid volume, acts as an incredibly complex molecular sieve, and, well, serves as the ultimate high-stakes battleground for your entire immune system.
It really is the front line.
It is. We will trace how it pumps fluid uphill against gravity without a central heart to drive it. We'll look at how it builds itself in utero, the brilliant architecture of its filtration organs, and what happens when this intricate plumbing gets blocked, bursts, or, gets actively hijacked by disease.
It is essentially the body's ultimate zero-trust security network. It just assumes that every single drop of fluid outside of your bloodstream is compromised.
Zero trust. I like that.
Yeah, it insists on interrogating all of it before letting it back into the general circulation. But to understand how it achieves this, we really have to look at the microscopic physics of why that fluid leaves the blood in the first place.
Okay, I want to visualize this. Imagine a drop of fluid inside one of the tiny blood capillaries in your finger right now. Why on earth would the body design a system where the pipes intentionally leak?
Well, it comes down to a battle of pressures. Physiologists call them Starling forces.
Starling forces.
Right. So every time your heart beats, it generates hydrostatic pressure. That pressure physically pushes outward against the walls of your tiny blood capillaries.
And those walls aren't solid, right?
No, not at all. They are incredibly thin and they are porous. They are specifically designed to let oxygen and nutrients out to feed your cells. So this physical pressure just forces plasma fluid to seep out into the microscopic spaces between your cells.
So the heart is essentially acting like a power washer, right? Just forcing fluid out through the tiny holes in the hose to water the surrounding tissue.
That is exactly what it's doing. But your blood also has a counterforce, which is oncotic pressure.
Oncotic pressure.
Yes. Your blood is full of large proteins, mostly albumin, that act kind of like sponges. They're desperately trying to pull that water back into the blood vessel.
Okay, so you have the power washer pushing it out and the sponges pulling it back in.
Precisely. But here is the critical physiological math. The outward push of the heart is slightly stronger than the inward pull of those proteins.
So there's a net loss.
A huge net loss. Every single day, your bloodstream loses about 3 liters of fluid into your tissues. This is what we call the interstitial fluid.
3 liters? I mean, that is a massive amount of standing water just pooling in the neighborhood of our cells.
It's basically a swamp.
Right. Microscopic swamp. It's carrying nutrients, but as you mentioned earlier, it's also gathering up the trash-dead cells, waste products, and, well, any stray bacteria that might have entered through a paper cut.
Yeah, you can't just leave that swamp water sitting there. No, you definitely can't. So how does the lymphatic system actually pull it out of the tissue?
This is where we meet the absolute origins of the lymphatic network, the lymphatic capillaries.
Okay.
They are interspersed right among your blood capillaries, but their design is completely different. I mean, a blood vessel is a continuous loop.
Right, it circulates.
But a lymphatic capillary originates blindly. It is a dead end. Picture a tiny, hollow, microscopic finger just sitting in the tissue bed.
A blind end. So if it's just a closed tube, how does the 3 liters of swamp water actually get inside.
Oh, the cellular engineering here is brilliant. The walls of these lymphatic capillaries are made of endothelial cells, but they aren't glued tightly together like they are in blood vessels.
How are they attached then?
Instead, the cells overlap each other, much like the shingles on the roof of a house.
Shingles. Okay, I'm picturing that.
And attached to these overlapping cells are tiny physical tethers called anchoring filaments. And these filaments attach directly to the surrounding tissue. Oh, I see where this is going. What happens when the tissue starts filling up with all that leaked fluid?
As the tissue swells with fluid, it physically pulls on those anchoring filaments. The filaments yank on the overlapping cells, and the shingles swing open inward.
Like microscopic swinging doors.
Exactly. They act as one-way swinging doors. The pressure outside is higher than the pressure inside the capillary, so the fluid, along with, large proteins, viruses, cellular debris, just rushes right into the capillary.
That is essentially a microscopic French drain.
The French drain.
Yeah, I mean, if you install a French drain in your yard, the perforated pipe only takes in water when the ground is actually flooded,
Yeah.
and the pressure pushes the water through the little holes.
Oh, yeah, that's a highly accurate way to model it. And just like a good drain, once the fluid is inside, it absolutely cannot go backward.
Because the pressure changes.
Right. As the lymphatic capillary fills up, the pressure inside rises, which physically slams those overlapping cellular flaps firmly shut. And once that interstitial fluid crosses the threshold into the capillary, its name officially changes. It is now called lymph.
Lymph. Okay, so we have millions of these microscopic French drains pulling in this clear, watery lymph from all over our body. But as we comb through our sources, there is a massive, highly specific exception to this clear fluid rule.
There is?
And it happens deep in our gut. Tell me about the gastrointestinal twist.
Right, we need to talk about the lacteals. In the small intestine, the lymphatic system basically moonlights as a digestive transport highway.
Digestion. I thought it was just drainage and immunity.
Usually, yes. But when you eat a meal, your blood capillaries are great at absorbing small molecules like amino acids from proteins or simple sugars from carbohydrates. But dietary fats, triglycerides, they are generally packaged into these large, bulky molecules called chylomicrons.
And they're too big.
Way too big. They're simply too massive to squeeze through the tight walls of your standard blood capillaries.
So if the blood can't take them, where do they go? I mean, imagine you just ate a heavily buttered piece of toast. How does that fat actually get into your system?
It gets absorbed by specialized lymphatic capillaries called lacteals. They sit right inside the little finger-like projections of your intestines, the villi.
And they can handle the size.
Oh, easily.
Yeah.
Because those overlapping cellular flaps of the lacteals can open so wide, they just easily swallow up these massive fat molecules.
Does all that fat change the nature of the fluid itself?
Dramatically. The lymph fluid draining from your gut isn't clear at all. Because it is incredibly rich in triglycerides and cholesterol, it is a thick, milky white substance.
Milky white.
Yeah, we give it a specific name. It's called chyle.
Chyle. Okay, so we have clear lymph seeping up from our toes and our arms, and this thick, milky chyle pouring out of our intestines. All of these tiny capillaries, they have to merge into larger and larger pipes. They have to consolidate somewhere.
They do.
Where is the final destination for all this fluid?
It all converges into two massive terminal vessels that dump the fluid directly back into your venous bloodstream right near your heart. We can think of them as the two great drains.
The two great drains.
But what is truly bizarre about this biological setup is how wildly unbalanced it is.
What do you mean unbalanced?
Well, the body usually loves symmetry, right? 2 lungs, 2 kidneys, 2 sides of the heart. The lymphatic system completely ignores symmetry.
I love when anatomy breaks its own rules. How uneven are we talking here?
Let's start with the dominant pathway, the thoracic duct. This is the massive superhighway of the lymphatic system. It is responsible for draining roughly 75% of your entire body's lymph volume.
75%. That is a staggering monopoly on the fluid. What specific territory is it responsible for?
It drains literally everything below your diaphragm, so both your legs, your entire pelvis, and your abdomen, including all that milky chyle from your gut.
Okay, so the whole lower half.
Right, but it doesn't stop there. As it travels up into your chest, it also takes the fluid from your left arm, the left side of your chest, and the left side of your head and neck.
That is a deeply asymmetrical map. So my right toe and my left ear are technically draining into the exact same pipe.
They absolutely are.
That's incredible. Where does this pipe actually start?
The thoracic duct usually begins deep in the abdomen, right around the level of your 12th thoracic vertebra. There is an expanded sac-like reservoir there called the cisterna chyli.
Cisterna chyli. It sounds like a Roman bathhouse.
It kind of acts like one. It's a pooling basin. All the clear lymph from your lower body and all the milky chyle from your intestines mix together in this basin.
Okay.
From there, the thoracic duct travels straight up through the chest cavity, arches over the left collarbone, and physically merges into the left venous angle.
What's the venous angle?
That is the exact spot where your left internal jugular vein meets your left subclavian vein. It dumps all that filtered fluid directly into the blood seconds before it enters the heart.
Wow. Okay, so if the thoracic duct handles 75% of the body, what about the remaining 25%?
That territory is handled by the right lymphatic duct. It is a much shorter, much smaller vessel. It only drains the right upper quadrant of your body.
So just the right arm, right chest, right side of the head.
Exactly. And it dumps its fluid into the corresponding right venous angle.
That structural imbalance is just fascinating. Why did we evolve to have one pipe do almost all the heavy lifting?
Well, it likely stems from the complex way the embryonic circulatory system folds and remodels itself. It prioritizes the most direct route for the largest volume of fluid, which is the abdomen and lower limbs, routing it to the left side of the heart's venous return.
But tracing the superhighway brings up a massive mechanical problem. I'm trying to visualize this fluid moving from my foot, up my leg, through my abdomen, and all the way up to my neck.
A long trip.
It's a huge trip. And we already established that the lymphatic system does not have a heart. It doesn't have a central pump generating high pressure. So how on earth does 3 liters of fluid travel uphill against gravity all the way to the collarbone?
Right.
If the capillaries are just passive drains, what is pushing the fluid?
If the system relied solely on passive fluid dynamics, you would constantly have severely swollen ankles. The larger lymphatic vessels, the collecting vessels, are actually highly engineered active pumping machines.
They pump themselves.
Yes. They are driven by a microscopic structural unit called the lymphangion.
Let's look closely at the lymphangion. How does it act as a pump?
Instead of picturing a collecting lymphatic vessel as a single smooth hose, you need to picture it as a chain of tiny muscular hearts strung together in a series.
Pointy hearts.
Basically, yes. Inside these larger vessels, there are one-way valves spaced a few millimeters apart. The distinct segment of the vessel located between 2 of these valves, that is the lymphangion.
So the vessel is highly compartmentalized. Thousands of microscopic chambers.
Thousands of them. And the walls of these chambers contain smooth muscle cells that act as pacemakers.
Pacemakers, like in the heart.
Very similar mechanism. As lymph flows into a lymphangion, the chamber fills with fluid and the walls physically stretch. This stretching triggers a reflexive contraction in the smooth muscle.
So it reacts to being full.
Exactly. The muscle violently squeezes, and when it does, the pressure inside that single microscopic chamber skyrockets.
And because fluids always take the path of least resistance, it tries to escape.
Right. But it can't go backward because the sudden spike in pressure slams the rear valve shut. The only way out is forward. The valve in front blows open, and the fluid is shot like a jet into the next lymphangion. Then that chamber stretches, its muscle contracts, and the cycle repeats.
It is a synchronized bucket brigade. But instead of just handing the bucket to the next person, each person is actively throwing the water as hard as they can.
That is the perfect way to visualize it. The biophysics here are so incredibly complex that researchers actually have to borrow mathematical models from electrical engineering just to map it.
Wait, electrical engineering?
Yeah. Our sources detail how scientists use what are called lumped parameter models. They essentially treat the lymphatic vessels like an electrical circuit.
That's wild.
They model the fluid pressure, like electrical voltage, the vessel resistance, like an electrical resistor, and the distensibility of the walls, like a capacitor.
So they're proving the physics mathematically.
Exactly. These models prove that the intrinsic contractions of the lymphangions are perfectly tuned to overcome the varying pressure gradients of gravity.
Okay, so that handles the intrinsic internal pumping. But we've all experienced that our ankles swell slightly on a long airplane flight, right?
Sure.
If these micropumps are always working, why does sitting still cause stagnation? Do our larger body movements contribute to the flow?
Massively. The lymphangions provide the baseline rhythm, but they really need help. Every time you contract the skeletal muscle, every time you take a step, flex your calf, or even just shift your arms, that bulky muscle physically bulges and squeezes the lymphatic vessels running through it.
So it's an external squeeze.
Right. This external compression dramatically increases the pumping force, forcing way more fluid upward.
So walking is literally wringing out the wet sponge of your tissues.
It really is. But the most powerful external pump is actually your breathing.
My breathing.
Yes.
Mm-hmm.
When you take a deep breath, your diaphragm drops, which expands your chest cavity. This creates a vacuum, a negative pressure zone inside your thorax.
Okay.
That vacuum acts like a giant syringe. It literally sucks lymph upward from the cisterna chyli in your abdomen, pulling it right up the thoracic duct.
I want the listener to try this. If you take a deep, deep breath right now, you are actively manipulating the fluid dynamics inside your abdomen. You're pulling a microscopic wave of fluid up toward your collarbone.
You are actively driving your shadow circulatory system.
But wait, we established early on that this fluid sweeping up from the tissues is a chaotic mix of cellular trash, leaked proteins, and wandering pathogens.
Right, it's very dirty fluid.
Yeah, and we just mapped out how this massive superhighway is relentlessly pumping all this raw, unfiltered fluid directly toward the jugular vein. If we dump live bacteria directly into the bloodstream just inches from the heart, wouldn't we die of sepsis every time we scrape a knee?
We absolutely would. The bloodstream is the ultimate VIP area. Once a pathogen is in the blood, it has unlimited access to every single organ in your body.
So we can't let it in.
We cannot allow raw lymph to enter the venous angle without an exhaustive security check.
Which brings us to the system's high-security filtration plants. We need to look at the architecture of the lymph nodes.
The lymph nodes are really the unsung, heavy-duty defenders of human anatomy. A healthy adult has roughly 800 of these scattered throughout their body.
800.
Yeah, highly concentrated in the neck, armpits, abdomen, and groin. Macroscopically, they look like small kidney beans. They generally range from 1 to 2 centimeters in length.
Pretty small.
Usually, yes. Though the sources note that healthy inguinal nodes, the ones in your groin, can naturally reach up to 20 millimeters.
Let's do a thought experiment here. Let's follow a single drop of lymph fluid that has just been pushed up by a lymphangion, and it's carrying a stray live bacteria.
Okay, I'm with you.
It arrives at the doorstep of a lymph node. How does it get inside, and what is the first thing it encounters?
Well, it doesn't just flow through a single wide-open tube. The fluid approaches the convex, rounded side of the kidney bean-shaped node. Here, multiple afferent lymphatic vessels, the incoming pipes, pierce right through the tough, fibrous outer capsule of the node.
Multiple pipes coming in.
Right. And the moment your drop of fluid crosses that capsule, it is dumped into a shallow receiving bay called the subcapsular sinus.
A receiving bay, so it just pools there for a moment.
Yeah.
But it can't just bypass the security guards, right?
Yeah. No, it is forced to percolate deeper. The inside of a lymph node is not a hollow sac. It is an intensely structured, densely packed labyrinth divided into very distinct zones.
Okay, what's the first zone?
From the subcapsular sinus, the fluid drips down into the outermost layer, which is the cortex.
What forces are stationed in the cortex?
The cortex is B lymphocyte territory. The B cells here are packed together into these spherical clusters known as follicles.
Follicles.
Yeah. If you were to look at a resting lymph node under a microscope, you'd see primary follicles. These are dense, dark clusters of naive B cells.
Naive meaning they haven't fought yet.
Exactly. They are soldiers who have never seen combat, just sitting there waiting for the specific antigen they were genetically programmed to fight.
But what happens when our wandering bacteria washes over them?
If a B cell recognizes the bacteria, the entire architecture of the cortex changes. That primary follicle transforms into a secondary follicle.
How does it transform?
The center of the sphere expands and becomes much lighter under a microscope. This lighter area is called a germinal center.
Why does it look lighter? What is physically happening in that space?
Extreme, furious biological activity. A germinal center is essentially a microscopic cloning factory.
A cloning factory?
Yes. The activated B cells are rapidly mutating their genetic code to create the perfect antibody, and then they're furiously multiplying and differentiating into plasma cells.
So they're multiplying so fast, they change how the tissue looks.
Right. The sheer speed of cellular division makes the tissue less dense, which is why it actually stains lighter on a slide.
So the cortex is the B-cell cloning facility, actively generating custom weapons. Where does our fluid travel next?
It drips deeper into the paracortex, or the inner cortex. If the outer layer belongs to the D cells, the paracortex is the exclusive domain of the T lymphocytes.
T cells?
Yes. And this zone contains one of the most mechanically fascinating structures in the entire immune system. They're called high endothelial venules, or HEVs.
Venules. Those are small blood vessels, right?
They are.
Why are we talking about blood vessels inside a lymphatic filter? I thought the whole point was to keep them separate until the end.
Because your immune cells don't just stay parked in a lymph node forever. T cells and B cells constantly circulate through the main bloodstream, patrolling the rest of the body.
Ah, okay.
But when a circulating lymphocyte arrives at a lymph node via the blood, it needs a way to exit the high-speed blood highway and enter the lymphatic tissue.
How does it cross the barrier without the blood just leaking out into the node?
It requires a highly specialized exit ramp. Most blood vessels are lined with flat, slippery cells to keep things moving fast, but the HEVs in the paracortex are lined with plump, cuboidal cells that physically project into the bloodstream.
Plump cells.
Yeah, and these cells are covered in specific surface receptors. Think of them like strips of molecular Velcro.
Velcro.
Exactly. As a lymphocyte zips by in the blood, it chemically snags on this Velcro. It rolls to a stop, flattens out, and literally squeezes itself between the cells of the blood vessel wall, migrating directly into the paracortex.
That is an incredible visual. It's like a moving walkway at a crowded airport, but the security guards on the side are holding out Velcro pads. If an immune cell brushes against it, they just yank it right through the wall and into the security room.
It is a brilliantly targeted recruitment system.
Okay, so that's the T cells.
Finally, after passing the T cells, our drop of fluid reaches the innermost core of the node, the medulla.
The medulla.
The medulla is organized into medullary cords, which are dense strands of antibody-producing plasma cells and macrophages, and these are separated by medullary sinuses.
Sinuses being the spaces between.
Right. These sinuses are the wider channels where the now filtered, heavily interrogated lymph fluid finally pools together.
And then it leaves the node.
Yes. All the medullary sinuses converge at a single indented area called the hilum, the inner curve of the kidney bean shape. The fluid exits through a single efferent lymphatic vessel, returning to the highway. But now it's significantly cleaner and carrying newly minted antibodies.
The structural logic of these zones is just beautiful, but I am still struggling with the physics of the filtration itself.
You know what you mean?
Well, if I pour a bucket of dirty water through a dense pile of sand, it still flows pretty quickly, right? If lymph fluid is constantly being pumped through these dense layers of B and T cells, how does the node actually trap a bacteria? I mean, how long does it take for a foreign antigen to actually get snagged rather than just washing right out the exit pipe?
The secret lies in a microscopic structure that we cannot even see with a standard microscope. It's known as the reticular framework.
Reticular framework.
Woven throughout the entire lymph node, through the cortex, the paracortex, and the medulla, is a fine three-dimensional meshwork made of type 3 collagen, and it's secreted by specialized reticular cells.
So the entire node is filled with a microscopic spider web.
Basically, yes, a web that dictates the fluid dynamics. This mesh acts as both a physical barrier and a molecular sieve. It forces the incoming lymph fluid to slow down dramatically.
So it kills the momentum.
Completely. The fluid doesn't rush. It is forced to seep through a labyrinth of tiny conduits. This extreme deceleration ensures that the lymph is thoroughly exposed to the macrophages that are anchored to the web.
So they're just sitting on the web waiting for the current to push something into them?
Oh, it's even more active than that. The macrophages literally extend long, arm-like pseudopods into the sinus spaces to just snatch up foreign particles as they slowly drift by.
Wow.
Furthermore, the physical gaps in this collagen mesh are incredibly specific. They are small enough that soluble antigens can filter through to be presented to the T and B cells. But larger, intact pathogens, like whole bacteria or, metastatic cancer cells, they become physically wedged in the mesh.
They get stuck.
They get stuck. They cannot easily slip through the framework to reach the efferent exit.
So it slows the river down to a crawl, physically wedges the invaders in a net, and gives the immune cells all the time they need to interrogate and destroy them. The engineering is flawless.
It is highly effective.
Mm-hmm.
But this intricate microarchitecture doesn't just magically appear out of nowhere.
Right.
The body has to physically build these 800 filtration plants while the fetus is still developing.
Which opens up a fascinating developmental puzzle. We know the cardiovascular system, the heart and the blood vessels, develops incredibly early in a fetus to supply oxygen. If the lymphatic system forms after the blood vessels, how does it integrate so perfectly without disrupting everything?
The embryology of the lymphatic system is a masterpiece of precision timing. It begins around week 6 of gestation, well after the main blood vessels have laid down their tracks.
Week 6. Yeah.
And the lymphatic system is actually born directly from the veins. Specific endothelial cells physically bud off from the embryonic cardinal veins.
So the venous system actively sprouts the lymphatic system.
Yes, these migrating budding cells form 6 primary pooling areas called lymph sacs. There is one cisterna chyli in the abdomen, one retroperitoneal sac, two iliac sacs down near the legs, and two jugular sacs up in the neck. Once these 6 foundational sacs are established, they begin sprouting primitive lymphatic vessels that grow outward into the tissues.
And they just follow the blood vessels.
Exactly, closely tracking the pathways already forged by the blood vessels.
Okay, that explains the plumbing. But how do you build a complex zoned filtration plant out of a simple sac?
The lymph nodes develop directly into these primary sacs. The surrounding mesenchymal tissue condenses and begins to physically bulge into the empty space of the lymph sac, creating the internal framework.
Bulging inward.
Right. The cellular timeline outlined in the sources is staggering. By week 13 of gestation, the incoming T cells begin to structurally organize the paracortex.
Week 13.
Yeah. By week 14, the B cells arrive and establish the outer cortex. And by week 20, you can actually observe those incipient primary follicles, the unactivated cloning factories, just waiting in the outer layer.
It is like watching a highly complex industrial city being built from the ground up, with all the different trades arriving precisely on schedule.
It really is.
But the sources highlight a truly bizarre temporary role these fetal nodes play right in the middle of construction, specifically between weeks 12 and 14. What are these half-built nodes doing before the immune system is fully online?
Oh, this is fascinating. During that highly specific 2-week window, the developing lymph nodes actually moonlight as bone marrow.
Wait, they manufacture blood?
They do. They undergo a process called granulopoiesis and erythropoiesis.
Why would they do that?
Because the actual bone marrow of the fetus is not yet fully mature enough to handle the massive demand for blood production. So the lymph nodes temporarily step in. They produce red blood cells, undifferentiated blast cells, and macrophages.
The body uses the developing lymph node as a temporary pop-up factory for blood, just to keep the fetus alive until the main factory is built.
It is the ultimate example of biological resourcefulness. And once the true bone marrow matures and takes over the heavy lifting, the lymph nodes immediately cease blood production and transition entirely to their lifelong roles as immune filters.
Speaking of biological resourcefulness, we have to talk about one of the most stunning evolutionary anomalies mentioned in our research.
The inverted nodes.
Yes, we just spent a significant amount of time detailing how human lymph fluid enters the outside of the node, filters through the cortex and medulla, and leaves from the center. It is an outside-in flow.
Right, outside in.
But the sources state that in pigs, rhinoceroses, hippopotamuses, and some cetaceans like whales, their lymph nodes are built inside out.
The inverted lymph node. It is structurally wild. In these animals, the afferent lymphatic vessels, the incoming pipes, bypass the outside capsule completely. They dive straight into the center of the node.
Straight to the core.
Yes. The B-cell follicles are located in the core, and the fluid flows outward, percolating toward the periphery.
And how do the cells leave?
When the mature lymphocytes are ready to leave, they don't exit through a central lymphatic vessel. They exit from the periphery directly into the general bloodstream via specialized efferent venules.
Wait, hold on. Let's think about this logically. If the lymph node works perfectly fine inside out for a 2-ton rhinoceros, why on earth did humans evolve to have it outside in? Is there some massive evolutionary advantage to our design? Are we the weird ones, or are they?
That is the exact debate among comparative anatomists. Is there a functional superiority, or is it just a genetic divergence?
What did the studies show?
Extensive studies on porcine pig lymph nodes indicate that these structural differences do not seem to impact the actual immunological functionality at all.
Really?
Yeah, the vital macrophage to B-cell interactions, the trapping of antigens, and the robust immune responses to viruses operate just as effectively in a pig as they do in a human.
So it's just a different architectural solution to the exact same physiological problem.
Precisely. Evolution is not about achieving structural perfection. It is about achieving functional survival. The ancestral lineage of these ungulates likely experienced a genetic shift in how their mesenchymal tissue folded during embryology.
And the inside-out design just worked.
It worked. It filtered pathogens and kept them alive. Because there was no lethal disadvantage, there was no evolutionary pressure to correct it. Biology just kept the blueprint.
It is a great reminder that anatomy is highly adaptable, but while a rhino can afford to have inverted nodes, knowing exactly how the human nodes are laid out is absolutely critical for our survival today. Because for medical professionals, the lymphatic system is not just an anatomical curiosity, it is a real-time diagnostic map.
Oh, absolutely. The lymphatic drainage patterns are the fundamental roadmap for tracking the spread of disease, particularly cancer and severe infections. If a doctor can feel a swollen node, they must know exactly which upstream territory that specific node is responsible for draining.
Let's trace this map, starting with the most complex geographical region, the neck, the cervical lymph nodes. Our medical sources break the neck down into 6 distinct numbered levels. I don't want to just list them. I want to understand how a doctor uses this as a tracking system.
Okay, think of the neck levels as a geographical breadcrumb trail. Level I encompasses the segmental and submandibular nodes. These sit right under your chin and along your jawline.
Thanks with the chin. Okay.
If a patient presents with a significantly swollen node in level I, the doctor isn't looking at their chest or their brain. They are going to open the patient's mouth.
Why the mouth?
Because they are looking for a severe dental abscess, an infection in the floor of the mouth, or maybe a lesion on the tip of the tongue. The drainage is highly localized.
So the location of the swelling immediately narrows the search grid.
Exactly. As you move deeper, level 2 involves the upper jugular nodes, high up near the base of the skull, draining the nasal cavity and the back of the throat.
And level 3 and 4?
Levels 3 and 4 track down the jugular vein. Level V covers the posterior triangle of the neck, sweeping out toward the shoulder muscle. And level 6 is the anterior compartment, sitting dead center right over the trachea and the thyroid gland.
So if a doctor feels a hard lump right over the Adam's apple in level 6, they are instantly evaluating the thyroid, not the teeth.
Exactly.
And this logic applies to the limbs as well, right?
It does. In the upper extremities, the lymph fluid drains toward the axillary nodes, located deep in the armpit.
And those are subdivided too?
Yes, into anterior, posterior, lateral, central, and apical groups. The anterior group is of paramount clinical importance because it is the primary drainage basin for the breast and the anterior chest wall.
Which is why breast cancer staging heavily relies on biopsying these specific armpit nodes.
Precisely.
And for the lower body.
The legs drain into the inguinal nodes, located in the groin within an anatomical region known as Scarpa's triangle. There are superficial nodes just under the skin and deep nodes nestled next to the major femoral blood vessels.
Now, let's put this geographical logic to the ultimate test. Our sources highlight several classic medical board scenarios where the obvious anatomical map completely breaks down and doctors have to rely on developmental history instead. Let's compare the lymphatic drainage of vulvar cancer versus testicular cancer.
This is one of the most profound diagnostic contrasts in surgical oncology.
How so?
If a female patient presents with a malignancy of the vulva, the primary lymphatic drainage follows the intuitive physical map. The fluid, and therefore the metastatic cancer cells, travel directly to the superficial inguinal nodes in the groin. The pathology drains to the closest regional catch basin.
Right. The groin drains to the groin. It makes perfect geographical sense.
But if a male patient presents with testicular cancer, the inguinal nodes in the groin are almost always completely bypassed.
Bypassed.
Yes. The cancer cells ignore the closest physical checkpoint and instead travel deep inside the body, metastasizing straight to the periaortic lymph nodes located high up in the abdomen, right next to the kidneys at the level of the L1 and L2 vertebrae.
If you look at that purely geographically, it makes absolutely zero sense. Why would a cancer in the scrotum entirely skip the local groin nodes and launch itself deep into the center of the abdomen?
To understand the pathology, you have to understand the embryology. You have to look at where the testes were born.
Where they were born.
During fetal development, the testes do not originate in the scrotum. They actually form high up in the posterior abdomen, right next to the developing kidneys.
Really?
Yes. As the fetus grows, the testes slowly descend through the inguinal canal and down into the scrotum.
But as they travel down, they don't sever their original connections.
Never. They drag their original blood supply, their nerves, and their foundational lymphatic drainage lines down with them, like a climber extending a rope.
Wow.
Therefore, the lymphatic highway for the adult testicle still leads directly back up that elongated rope to the periaortic nodes near the kidneys.
That is a staggering realization. The cancer is literally following an anatomical tether back to its origin story.
It is developmental history dictating modern pathology. It proves why doctors can't just think in 3 dimensions. They have to think in 4 dimensions, factoring in developmental time.
And perhaps the most famous and terrifying example of this long-distance medical detective work involves a very specific node on the left collarbone, known as Virchow's node.
Oh, Virchow's node, yes.
I want to dive deep into this because it brings us right back to our massive superhighway, the thoracic duct.
Right. So within level 4 of the neck nodes, the lower internal jugular group, there is a specific node located on the left side sitting just above the clavicle, the left supraclavicular node.
Okay.
In a routine exam, if a doctor palpates this specific node and finds it to be enlarged, hard, and completely painless, a clinical presentation known as Troisier's sign, it is considered a massive, immediate red flag.
Why is a painless bump on the left collarbone a red flag for the entire body?
You have to follow the plumbing. We established earlier that the thoracic duct drains 75% of the body, including the entire gastrointestinal tract. That massive duct travels all the way up through the chest and empties its fluid into the left venous angle, which sits right next to the left supraclavicular node.
Ah, I see.
Therefore, an enlarged Virchow's node very frequently indicates that a highly aggressive, silent cancer deep inside the abdomen, most classically a gastric or stomach cancer, has metastasized.
The cancer cells broke away from the stomach, entered the local lymphatic capillaries, got swept into the cisterna chyli, traveled all the way up the thoracic duct, and seated themselves in the very last node at the end of the line.
Exactly. It is the final catch basin before the venous blood. Finding cancer in Virchow's node is like standing at the mouth of a massive river and finding toxic manufactured debris washing up on the shore.
Wow.
With absolute certainty that somewhere far upstream, a hidden structural factory is dumping poison into the water.
That poisoned river analogy perfectly encapsulates the stakes of metastasis. The nodes act as the early warning buoys. But while lymph nodes are the most famous checkpoints in this system, they are far from the only ones. We need to zoom out and look at the heavy hitters. We need to explore the organs that manufacture, train, and deploy the immune system.
The lymphatic system operates on a very strict physiological hierarchy. The organs are broadly categorized into two distinct classes: primary lymphoid organs and secondary lymphoid organs.
Let's establish the difference. What grants an organ primary status?
Primary lymphoid organs are the genesis points and the foundational training grounds. They are the locations where lymphocytes are physically born and where they mature to immunocompetence.
So the bone marrow.
Yes. This category includes the bone marrow, which is the birthplace of all lymphocytes, and the specific maturation site for B cells. And it includes the thymus.
The thymus.
Right, which is the specialized boot camp, where T cells migrate to mature and learn how to distinguish foreign invaders from the body's own tissues.
So the primary organs are the military academies. What does that make the secondary organs?
The secondary organs are the active, forward-deployed combat zones. This is where the fully trained, mature immune cells actually function, filter fluids, and actively engage with foreign antigens.
So this is where the action happens.
Yes. This includes the hundreds of lymph nodes we just discussed, the spleen, and a vast network known as MALT.
Let's tackle the largest secondary organ first, the spleen. It's a fist-sized organ tucked under the rib cage in the left upper quadrant of the abdomen. If a lymph node is a filter, is the spleen just a giant fist-sized lymph node?
It is a filter, but its target is entirely different. A lymph node's primary job is to filter the interstitial tissue fluid. The spleen's primary job is to filter your blood.
The blood itself?
Exactly. It is a highly vascular, blood-gorged organ. And because its job is different, its internal histology, its microscopic architecture, looks nothing like a lymph node.
No cortex and medulla.
No. Instead, the internal tissue is radically divided into two distinct functional zones: the white pulp and the red pulp.
Let's follow the blood. When an artery brings blood into the spleen, what happens in the white pulp?
The white pulp is the immune surveillance division. It consists of structures called periarteriolar lymphatic sheaths, or PALs.
PALs. Okay.
Imagine a central arteriole, a small blood vessel running through the spleen. The PAL are dense, cylindrical sheaths of T cells wrapped tightly around that vessel, almost like a sleeve.
A sleeve of T cells.
Yes, and attached to these sleeves are spherical nodules packed with B cells. As the blood flows through the center, it is immediately and aggressively monitored by these immune cells for any blood-borne pathogens, like viruses or circulating bacteria.
So the white pulp handles the immune defense. What is happening in the red pulp?
The red pulp is the body's premier blood recycling and quality control center. It contains structures known as the splenic cords of Billroth, which are separated by highly specialized, leaky vascular sinusoids.
Cords of Billroth. Sounds intense.
It is an intense environment. As blood enters the red pulp, it slows down dramatically and is forced to percolate through a dense, physical obstacle course, guarded by a massive network of resident macrophages.
What are the macrophages looking for? Are they hunting bacteria here too?
In the red pulp, they are hunting your own red blood cells.
Our own cells. Why?
Because red blood cells have a lifespan of about 120 days. As they age, their cell membranes become stiff and brittle. The macrophages, in the cords of Billroth, physically test the flexibility of every passing red blood cell.
How do they test flexibility?
They force them through narrow slits. If a cell is young and pliable, it squeezes through the obstacles and returns to the circulation. If a cell is old, damaged, or misformed, it gets stuck.
And then?
The macrophages instantly recognizes the structural failure, grabs the defective cell, and completely destroys it, carefully recycling the iron back to the bone marrow to build new cells.
It is an incredible dual-purpose organ. Immune surveillance in the white pulp and structural quality control in the red pulp.
Right.
But what about the other secondary lymphatic tissue mentioned in the sources? We have the nodes filtering tissue fluid, the spleen filtering the blood. What is MALT? The sources define it as mucosa-associated lymphoid tissue.
MALT is the body's frontline border patrol. Think about the most vulnerable physical entry points into the human body: your mouth, your nasal passages, your airways, and your massive gastrointestinal tract.
Sure, they're exposed to everything.
Right. These surfaces are constantly, relentlessly exposed to the outside world, to the air we breathe, and the food we eat. MALT is a vast collection of unencapsulated lymphoid tissue stationed directly beneath the mucosal lining of these specific tracts.
So instead of waiting for a pathogen to cross into the tissue and travel to a lymph node, MALT puts the security guards right at the gates.
Exactly. The tonsils, the palatine, lingual, and pharyngeal adenoids, they form a defensive perimeter called Waldeyer's ring at the very back of your throat. They act as the first line of defense to catch inhaled or ingested pathogens before they can establish an infection.
And further down.
Further down, in the small intestine, you have concentrated areas of MALT called Peyer's patches.
Why does the intestine need localized security?
Because the human gut is home to trillions of bacteria. Most are helpful, but the balance is delicate. Peyer's patches constantly sample the massive bacterial load of the intestines, trapping and destroying invasive toxins and preventing the gut microbiome from breaching the intestinal wall and entering the bloodstream.
Wow.
Even the appendix, long thought to be a useless evolutionary remnant, is actually a dense collection of MALT, likely serving as a safe house for beneficial gut bacteria and a training ground for intestinal immunity.
That perfectly maps the secondary organs, but I want to circle back to one of the primary organs, the thymus.
Oh, the thymus.
Yes, because the sources mention a biological process regarding its life cycle that is fascinating and honestly a little depressing.
You're referring to thymic involution.
Yeah.
The thymus, located high in the upper chest just behind the sternum, is absolutely critical for the survival of the human species. It is the sole environment where T cells can mature and learn to tolerate our own tissues. But, it does not last forever.
What happens to it?
Well, the thymus is massive and highly furiously active during fetal development, childhood, and puberty. It is operating at peak capacity, training millions of T cells to build up a robust, lifelong immune repertoire.
Right.
But as we age and pass through puberty, the active lymphatic tissue of the thymus gradually begins to shrink. The highly cellular zones atrophy and are slowly replaced by inactive adipose tissue.
Fat.
Fat, yes.
It's like the body's elite boot camp gets systematically downsized as we get older, relying entirely on the veteran T cells that are already deployed out in the field.
That is a very accurate analogy. The thymus never completely stops working, but its output drops drastically. This process of involution is one of the primary reasons why immune responses fundamentally alter as we reach advanced age.
Which makes older populations more susceptible to new infections.
Exactly, and certain autoimmune issues.
Okay, up to this point, we have built an awe-inspiring, perfectly functioning physiological machine in our minds. We mapped the fluid dynamics, we explored the filtration plans, we traced the developmental history, and we armed the border patrol.
It's a great machine.
But biology is messy.
Very messy.
What happens in the real world when the pipes burst, get blocked, or get actively hijacked? We need to step into the clinical reality.
When the lymphatic system fails, the physical consequences are immediate and severe. The most common, overarching clinical manifestation of a broken lymphatic network is lymphedema.
Lymphedema.
Yes, it's a chronic, often debilitating condition characterized by severe localized swelling due to the massive accumulation of interstitial lymph fluid that simply cannot properly drain.
Our clinical sources broadly divide this into primary and secondary lymphedema. How do they differ?
Primary lymphedema is a structural birth defect. It is a rare, inherited congenital disorder where the lymphatic vessels or nodes simply do not develop correctly in utero.
So they're born with it.
Yes. The pipes might be severely malformed, too narrow, or in some areas, entirely absent. This condition often presents right at birth, or it can manifest during the hormonal surges of puberty.
Is there a way to surgically fix the pipes?
Unfortunately, because the systemic architecture is fundamentally flawed, there is rarely a definitive surgical cure. Management relies heavily on specialized physical therapy and lifelong external compression garments to physically force the fluid out of the limbs.
That sounds incredibly difficult to manage.
It is. However, while primary lymphedema is rare, secondary lymphedema is tragically common.
Secondary implies that the system was built perfectly, but an external force broke it.
Yes, secondary lymphedema is an acquired failure. The most frequent causes in the developed world are trauma, deep vein thrombosis, and very frequently the necessary surgical and radiation interventions for cancer.
Cancer surgery.
Right. Think back to our discussion of the axillary lymph nodes in the armpit. If an oncologist determines that breast cancer has spread to those nodes, a surgeon may have to perform an axillary lymph node dissection.
Meaning they remove them.
Yes, physically removing an entire block of nodes to stop the metastasis.
But by removing the cancerous nodes, they are also physically severing the primary drainage pipes for the patient's entire arm.
Exactly. The cancer is removed, but the fluid dynamics are ruined. The 3 liters of daily fluid still leak into the tissue of the arm, but it hits a dead end. The arm swells chronically. Modern surgery uses techniques like sentinel node biopsies to minimize this removal, but it remains a significant complication.
That makes tragic mechanical sense. You cut the pipe, the fluid backs up. But our global health sources describe a biological cause of obstruction that sounds like something straight out of a horror movie.
Lymphatic filariasis.
Commonly known as elephantiasis. How does a biological organism block a microscopic pipe?
This is a devastating mosquito-borne parasitic infection that is highly prevalent in tropical and subtropical regions across the globe.
Mosquitoes again?
Always mosquitoes. The cycle begins when an infected mosquito bites a human. Instead of transmitting a virus like malaria, the mosquito injects microscopic, thread-like parasitic worms, nematodes, directly into the bloodstream.
And these worms specifically target the lymphatic system.
They do. They migrate out of the blood and navigate directly into the lymphatic vessels and lymph nodes. And once they arrive, they take up residence.
They just live there.
They live, they mate, and they multiply, physically nesting inside the lymphatic channels.
A nest of worms inside a vessel that is only a few millimeters wide.
The mechanical blockage is profound. The sheer physical volume of the adult worms, combined with the extreme fibrotic inflammatory response the human immune system launches to fight them, completely destroys the delicate one-way valves of the lymphangions.
So the pump is destroyed.
The flow of lymph is halted entirely. Over years of chronic infection, this causes massive, disfiguring lymphedema, leading to extreme swelling and severe thickening of the skin and underlying tissues, elephantiasis.
It's horrific.
It most commonly affects the lower extremities and the genitals, and it stands as the second most common cause of long-term physical disability in the world.
It is a literal biological hijacking of the drainage system. But what about when the massive superhighways are damaged rather than just blocked? Our surgical sources mention a catastrophic complication called a chylothorax.
Oh, a chylothorax.
Right.
We talked extensively about the thoracic duct, that massive highway carrying the milky, fat-rich chyle up from the gut through the chest.
Right, the 75% drain.
Anatomically, the thoracic duct is very thin-walled, and it runs deep in the posterior mediastinum, seating incredibly close to the esophagus and the descending aorta.
So it's right next to major structures.
Because of this proximity, it is highly vulnerable during complex thoracic surgeries, such as an esophagectomy, the removal of the esophagus.
So if a surgeon is operating on the esophagus and their scalpel slips by a fraction of a millimeter.
If they accidentally nick or sever the thoracic duct, the consequences are immediate. All of that milky, triglyceride-rich chyle being pumped upward by the abdominal vacuum begins leaking directly into the pleural cavity.
The space around the lungs?
Yes.
That sounds like a mechanical nightmare. The chest cavity is filling with a milky fat emulsion.
It is a major, life-threatening complication. The accumulating fluid physically compresses the lungs, causing acute respiratory distress. Furthermore, the body is rapidly draining massive amounts of essential dietary fats, fat-soluble vitamins, and mature T lymphocytes out of a hole in the pipe.
So you're losing your immune cells too.
If not surgically repaired or managed with specialized drains and zero-fat diets, it leads to rapid, severe malnutrition and profound immunodeficiency.
Wow. We've covered blockages and we've covered leaks. But when a patient simply presents with an enlarged, mysterious node, How do modern doctors actually figure out what is wrong inside that tiny fibrous capsule?
It can be tricky.
If it's deep inside the chest or the abdomen, you can't just feel it with your hands. What is the advanced diagnostic toolkit?
Let's say a scan reveals an enlarged lymph node deep in the mediastinum between the lungs. To figure out what is inside, doctors rely on endoscopic ultrasound, or EUS, combined with fine needle aspiration, FNA.
How does that work in practice?
They guide a flexible endoscope, equipped with a high-frequency ultrasound probe, down the patient's esophagus or stomach. Because the internal organs are resting right against the lymphatic chains, the ultrasound can perfectly visualize the enlarged node right through the stomach wall.
Oh, so they look through the wall.
Once they have a clear image, they pass a microscopic hollow needle through the endoscope, pierce the stomach wall, enter the lymph node, and aspirate or suck out a sample of the cells.
That sounds incredibly precise.
Our clinical literature notes that EUS-FNA is the gold standard for this kind of evaluation, boasting up to 85% sensitivity and near 100% specificity for detecting and staging malignancies without requiring open surgery.
But what if the node is in a location that is too dangerous to reach safely with a needle, even with an ultrasound? Are there non-invasive ways to kind of feel the node?
That is where a technique called elastography comes in. Elastography is essentially a virtual biopsy. It uses specialized ultrasound waves to measure the physical stiffness and elasticity of the targeted tissue.
Why does stiffness matter?
Because cellular density changes with disease. A lymph node that is swollen because of a benign reactive infection is generally soft and pliable. But a lymph node that has been infiltrated by tightly packed desmoplastic cancer cells is structurally rigid.
So it feels different to the sound waves.
Exactly. By measuring how the sound waves compress the tissue, the machine can map the stiffness, giving oncologists a highly accurate prediction of malignancy without ever breaking the skin.
That covers evaluating a single specific node. But what if a doctor needs to know exactly how far a cancer has spread across the entire 800-node network? I want to dive deep into PET-CT scans because they are heavily emphasized in our oncological sources. How do they track the disease?
Positron emission tomography, combined with a CT scan, is arguably the most critical tool for the functional and anatomical staging of advanced cancers. It does not just look at the shape of the organs, it looks at their metabolic appetite.
How do you measure an organ's appetite?
The patient is injected with a specialized radioactive tracer, most commonly FDG, which is a modified form of glucose or sugar.
Radioactive sugar.
Right. Here is the physiological reality of cancer. Malignant cells divide uncontrollably, and that chaotic division requires a massive, relentless amount of energy. Cancer cells consume glucose at a rate far higher than normal healthy tissue.
So they're structurally starving for sugar.
Yes. So when the radioactive glucose is injected, the cancer cells rapidly absorb it. When the patient is placed in the scanner, those areas of intense radiation accumulation literally light up on the monitor as bright hotspots.
That's how they find it.
This allows the oncologist to scan the entire body and see exactly which lymph nodes, whether in the neck, the armpit, or deep in the abdomen, have been seeded by the metastatic cells.
It sounds like a diagnostic silver bullet. I mean, the cancer eats the radioactive sugar and reveals itself. But our sources are very clear that PET-CT has some major dangerous pitfalls in its interpretation. Where does the scan fail?
The fundamental flaw of the PET scan is that it is incredibly sensitive, but not perfectly specific. It highlights anything that is consuming a lot of glucose. And cancer is not the only biological process that demands immense energy.
What else eats that much sugar?
Severe inflammation and active infection. If a patient has a massive bacterial infection, the lymph nodes in that region are rapidly multiplying B cells and fighting a microscopic war. That requires enormous energy. Therefore, a perfectly benign reactive lymph node fighting a standard infection will aggressively consume the radioactive glucose and light up on the PET scan, perfectly mimicking a metastatic tumor.
So radiologists could look at a scan, see a glowing node, and incorrectly diagnose advanced cancer when the patient just has a severe localized infection.
That's exactly the pitfall. Furthermore, in younger patients, normal thymic tissue can appear hypermetabolic.
The thymus again?
Remember the thymus. In young people, it is still furiously active, training T cells. It can light up brilliantly on a scan, confusing an inexperienced diagnostician into thinking there is a massive tumor in the chest when it's simply a healthy thymus doing its job. This phenomenon is known as thymic hyperplasia.
So the imaging is a powerful tool, But it is blind to context. It must always be rigorously correlated with the actual clinical picture and physical biopsies.
And it also involves a very high dose of ionizing radiation because it requires a whole-body CT scan to map the anatomy. It is not a tool to be used lightly.
Let's assume they do the scan, they find a suspicious node, and they successfully extract cells using that FNA needle. When the pathologists look at those cells under a microscope, what are they actually looking for? For instance, what if it isn't cancer, but an ancient, stubborn infection like tuberculosis?
Pathology is all about pattern recognition. In the case of tuberculosis, the pathologist is looking for a very specific microscopic architectural structure called a granuloma.
What exactly is a granuloma? Is it the bacteria itself?
No, it is the immune system's physical monument to a battle it cannot win.
A monument.
Yes. The bacteria that causes tuberculosis, Mycobacterium tuberculosis, is incredibly resilient. Often, the macrophages inside the lymph node engulf the bacteria, but they cannot digest its tough, waxy cell wall. The bacteria survives inside the macrophage.
So the security guard swallowed the intruder, but the intruder is still alive in their stomach. What does the immune system do?
It resorts to containment. The infected macrophages release chemical signals calling for backup. Hundreds of other macrophages swarm the area. Recognizing that they cannot kill the bacteria, they physically surround it to wall it off from the rest of the body.
Building a wall of bodies.
Exactly. These macrophages undergo a structural change, flattening out to look like skin cells. These are called epithelioid histiocytes.
They're literally building a fleshy wall.
It goes even deeper than that. Some of these macrophages realize that a single cell wall isn't strong enough. So multiple macrophages literally fuse their bodies together, combining their cytoplasm and nuclei into massive, multinucleated entities known as Langerhans giant cells.
Fusing together, that is wild.
This tight microscopic sphere of fused and flattened macrophages surrounding the undying bacteria is the granuloma. When a pathologist sees that structure on a slide, they know they are dealing with a severe chronic granulomatous disease like TB.
That is a stunning level of cellular cooperation. But what happens when the cells cooperating are the problem? We cannot conclude our discussion of lymphatic system failure without addressing the absolute worst-case scenario. What happens when the immune cells themselves become the enemy?
We have to discuss lymphoma.
Right.
Lymphomas are a group of blood cancers that originate directly from the lymphocytes, the B cells and T cells that live within the lymphatic system. They are generally categorized into Hodgkin lymphoma and non-Hodgkin lymphoma, based on the specific presence of certain mutated cells.
How does the system designed to kill cancer become cancer?
It comes down to a catastrophic malignant transformation. In a healthy lymph node, B cells rapidly divide in the germinal center to fight an infection. Once the infection is cleared, the chemical signals tell those millions of newly cloned cells to undergo apoptosis-programmed cell death.
So they die on command.
They did their job, and now they must die so the node can shrink back to normal. But in lymphoma, the genetic code of a B cell or T cell mutates. It ignores the kill signal.
It refuses to die, and it just keeps multiplying.
Uncontrollably. The mutated lymphocytes pack into the lymph node, causing it to swell massively. But unlike a localized solid tumor, lymphoma is a cancer born into the highway.
They already have a built-in transport system.
Sadly, yes. Because they are native to the lymphatic fluid, they can easily use the efferent vessels to disseminate across the body, colonizing other regional nodes, infiltrating the spleen, and eventually entering the bone marrow.
And our sources point out a very specific clinical scenario where this risk is drastically amplified. What happens with lymphoma in patients who are immunocompromised, specifically those living with HIV?
It is a critical oncological intersection. Patients living with untreated or advanced HIV have significantly depleted levels of CD4 T cells, the orchestrators of the immune system.
Right.
One of the lesser-known jobs of a healthy immune system is constant tumor surveillance. Healthy T cells and natural killer cells constantly patrol the body, looking for cells that have mutated, and they destroy them before they can become full-blown cancer.
So they act as internal quality control.
Exactly. But in an immunocompromised or HIV-positive patient, that surveillance network is broken. If a B cell in a lymph node mutates into lymphoma, there are no healthy T cells around to recognize the error and kill it.
It just grows unchecked.
Furthermore, HIV patients are frequently co-infected with oncogenic viruses, like the Epstein-Barr virus, which actively drives B cells to mutate. The combination of viral mutation and zero immune surveillance causes the risk of aggressive, high-grade lymphomas to skyrocket in these populations.
The presentation of lymphoma is crucial to understand. So Let me pose a scenario. I wake up tomorrow morning, I look in the mirror, and I notice a visibly swollen lymph node right under my jaw. The classic 3 a.m. internet symptom panic sets in.
Oh, we've all been there.
How do I, or how does a doctor, differentiate between a node that is just packed with B cells actively fighting a common cold and a node that has suffered a structural malignant failure like lymphoma?
It is the ultimate 3 a.m. medical panic, but the clinical context provides very clear guidelines. Reactive lymphadenopathy swelling due to a standard infection behaves in a predictable way.
Predictable how?
It is doing exactly what it was designed to do. The node swells quickly, often over a day or two. Because the tough fibrous capsule is being stretched so rapidly by the fluid and multiplying cells, it is usually quite painful or tender to the touch.
Wait, pain is actually a good sign.
In this context, acute pain suggests rapid benign expansion, and most importantly, reactive swelling resolves. Once your immune system clears the throat infection, the node shrinks back to its normal, unnoticeable size within a couple of weeks.
So what are the clinical red flags that suggest I actually need a biopsy?
We worry when the swelling breaks those rules. We worry when a node is persistently enlarged for many weeks without any obvious upstream infection.
Like a cold or cut.
Right. We worry if the node feels rock hard or if it feels physically fixed and immobilized to the underlying tissue. And paradoxically, we worry deeply if the massive swelling is completely painless.
Because it's slow.
Because slow-growing malignancies often stretch the capsule so gradually that the pain receptors aren't triggered.
Painless, hard, and fixed.
Yes. We also look for extreme asymmetry, like finding a massively enlarged left-sided Virchow's node while the right side is completely flat. Finally, oncologists always look for accompanying systemic symptoms, often called B symptoms in lymphoma.
What are B symptoms?
These include drenching light sweats that soak your sheets, unexplained fevers that come and go, and sudden significant weight loss without trying. If you lack those red flags, and you just have a sore throat and a tender lump under your jaw, your lymphatic system is just doing its job beautifully.
That is deeply reassuring context to pull us out of the 3 a.m. panic.
I hope it helps.
Okay. We have traveled a massive physiological distance today. We started with the microscopic physics of interstitial fluid leaking from the capillaries. We mapped the overlapping cellular doors, rode the fluid up the muscular, pumping lymphangions of the thoracic superhighway, and navigated the dense collagen meshes of the lymph nodes.
We covered a lot of ground.
We dug into the embryonic genesis of the system, debated the inverted nodes of rhinos, translated the medical map of the neck, explored the boot camps of the spleen and thymus, and finally looked at the tragic realities of structural failure, parasitic hijacking, and malignant transformation.
We have thoroughly illuminated a system that prefers to operate in the shadows. We have mapped the ghost town.
We have. But before we wrap up this deep dive, I want to leave you, the listener, with a final provocative thought drawn from the cutting edge of our sources. A thought that proves that despite all our advanced technology, we are still actively mapping the human body today.
Oh, the discovery you're referring to is a truly paradigm-shifting moment in modern biology.
For decades, the absolute bedrock of medical science taught in every medical school in the world was the firm belief that the central nervous system, meaning the brain and the spinal cord, was completely devoid of any lymphatic vessels.
That was gospel.
We believed the brain was an entirely isolated, privileged organ protected by the blood-brain barrier, handling its own waste clearance independently. But very recently, researchers proved the textbook's entirely wrong.
They discovered fully functional lymphatic vessels hiding in plain sight.
Where?
They are running directly through the cranial meninges, the tough, protective membranes surrounding the brain. These hidden vessels are actively clearing cerebrospinal fluid, cellular waste, and immune cells out of the central nervous system and draining them straight down into the deep cervical lymph nodes in the neck.
And they didn't just find them in the brain. Recent studies have also identified functional lymphatic-like structures known as the Schlemm canals operating inside the human eye, managing the clearance of ocular fluid.
This completely upends our understanding of neuroimmunology. It forces medical science to drastically reevaluate how devastating neurological diseases like Alzheimer's, which involves the buildup of toxic plaques, or multiple sclerosis, might actually be linked to a failure in this newly discovered brain drainage system.
Exactly. It opens up an entirely new frontier of medicine. So here's the thought I want to leave you with. If, in the 21st century, Armed with our advanced MRI machines, our hypersensitive PET-CT scanners, and our electron microscopes, we are still discovering massive, hidden anatomical drainage networks operating right inside our own heads. What other invisible physiological systems are operating inside of you right now, completely undetected?
It is a humbling reminder that the human body is a universe unto itself, and it is still holding on to a few of its deepest secrets.
It really is. Thank you for joining us on this deep dive into the hidden architecture of the lymphatic system. Keep questioning the obvious and stay insanely curious.